So hello listeners, welcome to this 20th episode of Blood Matters, a podcast for nurses. This is our third season and we have a quite a new format this season. It will be shorter to about 20 minutes and we have one guest and we will do a more informal conversation with this guest. And today I am here as your co-host and my name is Hilda Mekelenkamp and my other co-host is Michelle Kenyon. Welcome to Michelle.
Hi Hilda, hi everyone.
And we have a wonderful guest, which is Lynn Leppla. She is a postdoctoral researcher at Basel University and a clinical nurse specialist at the Hospital Freiburg. Welcome to you, Lynn.
Yeah,
Michelle,
hi Hilda, hi Michelle.
Lynn.
Hi, Lynn. So, Michelle, can you start the conversation with Lynn?
Yeah, sure. Hi Lynn. Would you like to just tell us a bit about yourself? I mean, I know that Hilda's given a very brief overview, but I think you have a very interesting role.
Yes, actually, from background, I'm a trained oncology nurse with like about 20 years experience in caring for hematologic patients. And since 2013, I started focusing only on the allotransplant patients. And like 7 to 10 years ago, I started my PhD or my research program, and then I tried to combine or have a synergistic interplay between my clinical work and also the research and educational parts, which is very interesting, I think, and gives me a lot of more insights to generate more evidence and learn more in this field. Yeah.
Thanks so much, Lynn. And in this new season, as Hilda said, we have a slightly different format. And in this episode particularly, we're going to start tackling graft versus host disease, in particular gastrointestinal or gut graft versus host disease. And so what we'd really like to do is kind of dig into that topic a little bit, its importance, some of the symptoms. We know that, it has such a significant impact on patients' quality of life, and we're going to talk about that a little bit later on in the pod. But, these poor, unfortunate patients, have such intractable symptoms with nausea and diarrhea. And, we do a lot of unpleasant investigations to try and understand the disease and to make a diagnosis. And that has quite a significant impact on patients. Can you tell us, Lynn, a little bit about your experiences with gastrointestinal graft versus host disease and working with patients who experience this?
Yes, of course. I mean, as most of the listeners probably know, that graft versus host disease is one of the major complications, and as you mentioned, it significantly contributes to the mortality and also morbidity. And here, the gut GvHD is outstanding compared to the other forms of acute and also chronic GvHD. So, in the patients affected of acute GvHD, up to 50% of these or 70% of these patients develop or have a gut involvement in their GvHD. So, and sometimes it's only found in the upper gastrointestinal tract, but sometimes only in the lower GI tract, but mostly it's affecting both parts of the GI tract, and this is very severe for our patients. And yeah, and as you mentioned, these patients suffer from a variety of symptoms, really demanding them in their quality of life and also, in their well-being.
And I guess in addition to the unpleasant experience of the graft versus host disease itself and the difficult investigations, then we're also adding more medications, and our patients are experiencing side effects of that. I think sometimes there can be a little bit of confusion around graft versus host disease, and it'd be great to kind of highlight one or two areas that are kind of frequently misunderstood in relation to graft versus host disease. Is there anything that springs to mind for you, Lynn, on that?
I think one common misunderstanding around GI GvHD is maybe that diarrhea is not automatically assumed to be a GvHD related symptom. So it can also have different reasons why patients have diarrhea. It can be related to the conditioning regimen, to other medications, to infections. And I think we need to be very aware in screening our patients on a regular basis for superinfections, because they have a quite high risk as soon as they have a GI GvHD for secondary infections. And sometimes they have both, like first GvHD, then an on top infection, and this triggers each other and makes it even worse. So if we I think this is one of the core competencies of nurses, to be very aware of these problems, and because we are so close to the patients and can monitor them very closely, and make sure that we early detect these additional complications. Maybe.
Yeah, I agree with you, Lynn. You know, you can get that kind of inflammatory process that happens with an acute infection in the gut, and then you then can see this kind of GI symptomatology kind of continuing. So it's important to continue to investigate and reinvestigate these patients if they're not improving with the treatment. And of course, as we see, you know, the treatment of infection, the treatment of graft versus host disease is very different, right? So, you know, one is a kind of an antibiotic or maybe an antiviral, and then the other is immunosuppressive. So, you know, you can end up being in a really difficult spot with these patients. Hilda, have you anything that you wanted to add within the issues of difficulties with diagnosing or misdiagnosing GI GvHD?
Yeah, I think one of the main challenges is also the anxiety from the patient's perspective, because as soon as kind of these symptoms start, we always see in the patients the anxiety that this should be the GvH, where they are very anxious for all the time, and where they are informed about that we should avoid it, etc. What can you say about that, Lynn, from your experience? How should we handle that, and what are the best advices in those situations?
For the patients, you mean, or also for the colleagues? I think those we have both.
I think that are definitely two parts for sure. Yeah.
Yeah. I think maybe I start from the emotional side, from the patients, because I think for them it's very, as we already mentioned, demanding, and they maybe some of them even stop eating in fear of getting diarrhea worse than before, or they start reducing drinking or intaking anything because they fear to have abdominal pain episodes or something like this. And on the other side, also patients have sometimes the idea of it's good to have severe GvHD because then my new stem cells are working, but actually that's not what we want. I mean, there's a difference between having a mild GvHD and a severe GvHD, and severe GvHD is always very dangerous for our patients. It immediately puts up the mortality for these patients by, I think it was a fourfold risk they have or they are confronted with. So, and I think, on the other side, also for the colleagues, I think it's a challenge to care for these patients because they have to observe their stool frequency to monitor, but also do a structured symptom assessment, and should also be aware of all these accompanying symptoms and addressing these and give some support. And I think what we also need to make sure is that we involve all the other healthcare professionals or like social workers, dietitians, psychologists, to have a good supportive structure around the patients. And also we need to also think about their caregivers. For them, it's also challenging to go through these phases.
Do you think, Lynn, that and Hilda, do you think our nurses are always fully understand the reason for measuring stool volume and frequency, or do you think it kind of gets sort of benched a bit like, you know, measuring urine output? Sometimes that's a bit inconsistent as well.
I'm not sure actually. Maybe we should assess that.
Yeah,
If nurses
yeah.
are always aware of that. But I think on the one side, it's very important for doing the right grading. Like
Yeah.
when you use the MAGIC or Klucksbeck criteria, you need not only the amount of diarrhea, but also how it looks like and if it goes along with symptoms. So we really heavily rely on a good assessment of
Yeah.
the frequency, but also on the symptoms. And I think this is something nurses should be very aware of. That their proper assessment has a consequence for the colleagues of our medical colleagues, because they are doing the grading based on
Yeah.
this, and also the evaluation of the therapy they started. So
yeah, I guess it's also an opportunity for patient education as well, right? So, you know, some of our patients are being managed with a GI GvHD in the home environment, and so being able to articulate and report stool frequency and volume and appearance from a patient perspective is also very important. But often when our patients are hospitalized with GI GvHD, they feel too unwell to really be interested to be able to do that self-monitoring or vigilance. And I think that makes it difficult for our ward teams if the patients have been quite independent with that, but then they stop to do it. And I think there is a kind of cut-off, isn't there, where our nurses need to kind of be aware and then take over that role. Ultimately, that needs to be happening. Hilda, do you have any experiences with that? The patients
Yeah,
you're
of
looking after?
course. Yeah, it's really important that nurses should step in. And I think they are the first observing those different stool frequencies, and especially my experiences in children. And I think there it is really important. And volumes can be very different because of the volume for an adult. It can be large, but for a child, you should be very carefully weighing things and measuring things, etc. So that's really important. And what also came to my mind is one of the most difficulties is, I think, handling the pain for these patients, because these GI GvHD causes so much pain, and it's really a challenge to keep track on that. And I was wondering what your experience are with that, and also to ask the pain specialist for this, for example.
Yes, yeah, we usually involve pain specialists if we have, if we observe that our initial treatment doesn't help that much, but also what Michelle mentioned, I think to assess or to ask for patient-reported outcomes is quite important, because then it enables you to better tailor your treatment to the needs of the patients. And this was also part of my research, where we developed like the SMILE monitoring software, which allowed us to ask patients to report on their symptoms every day at a very easy and low threshold. And of course, as Michelle said, sometimes they are so tired and so sick that they are not able to use it every day. But then, interestingly, the caregivers take over and they enter their data, and then this enables us really nicely and really fast to react on symptom changes. And I think this might be something also for other transplant centers in the future, to have systems in their centers allowing them to do a remote monitoring of the patient-reported outcomes. But yeah, I think there's still a lot to do in terms of regulation and also research. But the first studies are around, and this is maybe promising and also important, I think. Yeah.
Yeah, and what are your
Thank-
plans with that app? Are you planning to roll it out to other centers? What are your expectations?
Yes, we really try, but as I mentioned, this is also challenged by regulations of the different countries, and even in Germany, it's a challenge. And you need to find a company which is investing in further developing such a tool, because the population is quite small of stem cell transplanted patients. But I mean, it wouldn't be that complicated to roll it out or to scale it up to other populations. But you need to have one visionary company going with you this way. And we are currently in discussions with a company, and hopefully we will be able to run maybe a European-wide study and to get some more insights on that, how effective it can be. Because in our small sample, we saw that we could improve the mortality for patients. For example, it was not a significant finding because we had such a small sample size, but still, I think it's an important signal in the data. And if we could verify this by a larger sample size, would be great. And we also saw quite a large reduction in the risk for developing a graft versus host disease. It was about 50%. And I was really impressed by this finding, because I thought, okay, we just try to modify this soft variables, like educating the patients about their medication adherence, supporting them and assessing their symptoms, or like these, or helping them to early detect and react on their symptoms. And this makes such a huge difference. So I think we really need to be more aware of these soft factors, and not only, and I think that's also the nurses' objective rather than the physician's objective. Yeah.
So Lynn, you already explained a lot about the GI GvHD, and also the symptoms. We discussed the symptoms patients' experience and how they can track on that. And yeah, probably can you dive a little bit deeper into what kind of symptoms patients experience as most burdensome during the GvHD?
Mm-hmm. Yeah, interestingly, for gut GvHD, there's not much research, especially for gut GvHD. I was very astonished to see that when I prepared my talk for the EBMT annual meeting. But in general, for GvHD, of course, there's a lot of research on symptoms and symptom burden and symptom experience of patients. And here are some very nice papers around from the last 2-3 years. One paper is published in Cancer by you and colleagues in 2033, and they nicely showed how all these symptoms impact the quality of life and also the daily activity living of these patients. And here you see that patients are often unable to go even out for shopping or to driving their cars or doing their household. And they also describe symptoms like the diarrhea as very burdensome, but also other symptoms like nausea, vomiting. They are more related to the acute GI GvHD, but in the chronic form, you have then symptoms like malabsorption leading to less proteins, leading to edema and maybe weight loss. And so it's more chronic long-term problems associated with the chronic gut GvHD, but still it's demanding, and many of these patients need maybe home parenteral nutrition or something, which is again associated with other problems. So it's like a line of problems as coming together. And maybe you cannot say which is the most distressing symptom. I think it's the composition of all, making it so challenging for our patients and their caregivers. Yeah.
Yeah, it also means a lot for the caregivers. You mentioned that before, and I think as nurses we have an important role in supporting them as well. And I think we are also confronted with their uncertainties, etc. What can you tell from your experience, Michelle, about that with the caregivers and the carers around these patient categories?
Yeah, sure. I mean, something that Lynn was saying then around kind of symptom burden, and it's not something that is very easy to measure, right? So in the paper that you referred to, I saw that dry eyes were one of the most frequently reported symptoms. But of course, you know, as a caregiver or as a friend or a colleague, you can't see that in somebody. Yes, you might notice the frequency with which they put some drops in their eyes, but you know, you don't necessarily see that, because this could be happening in a person who presents themselves as otherwise very well. So I think that the symptom burden we need to remember as health professionals, but also to help educate family members that the symptom burden is what the patient says it is, right? So some of those things we just can't objectively measure, like pain and discomfort, dry eyes, dry mouth. And so the degree to which that then impacts somebody's quality of life, and the degree to which that can impact family relationships can be quite significant. And it's not necessarily the most burdensome graft-versus-host disease that causes the most difficulty, but it can be those unseen, not very well understood groups of symptoms that can really impact on somebody's quality of life and impact on caregiver burden potentially as well. You know, I think it's really important to think about the caregivers, but also to ensure that caregivers have access to educational resources as well with graft-versus-host disease, so that they feel better informed, perhaps a little bit better in more in control of the way that the graft-versus-host disease is happening, I think. Yeah.
Yeah, thank you. Yeah, and we will put the link to the article you are referring to also in the comments below the podcast. And Lynn, we are really discussing this already a little bit, and the dry eyes was really the most burdensome symptom in patients. Did you expect that, and do you see this also in your studies and in your practice as well?
Actually, yeah, we didn't see it in our study because the SMILE was constructed to assess acute GvHD symptoms, and the eye is mostly affected by chronic GvHD. Sometimes you also have acute, but we are currently working on a module for chronic GvHD, but that's why I can't say much about dry eyes in our study sample. But in general, I also observed this. Last week, I had a patient come visiting me in the outpatient care and she was so depressed because she had so much pain in her eyes. She couldn't see right. The vision was blurred, and this was so heavily influencing her daily life and her quality of life. I was really concerned letting her go back at home because she was so sad and so I tried to coordinate a psychological support for her and to make it somehow better, but often it's like you feel like you have no treatment options anymore. You already tried everything and already tried to support these patients with everything, but I think the effect, the eyes are really affecting patients' emotional sides very much. And as Michelle said, you can't see it from the outside. They look like normal.
Yeah. Yeah, and you have that expectation that if somebody looks normal and then that they'll be, you know, they don't have any problems. So I think the unseen burden of graft-versus-host disease, I think, is one of the most challenging things for us as health professionals, but also for patients, because it's so hard for them to explain and convince people that they have ongoing symptoms. I think when we talk about kind of treatments being a bit more limited, I think there is, you know, some excitement with advances in treatment. We now see that there are new drugs that have become more widely available. And what are your experiences with those?
Yes, I think as usual, we start with steroids and then we continue with treatments like ruxolitinib, for example, or other immunosuppressive medications. But as you said, there's a lot of going on in research about treatments, and particularly for coming back to the GI GvHD, there's one promising study I heard also at the annual meeting, the Stargate trial. I don't know if you heard about it, which is currently evaluating the combination of ruxolitinib and apraglutide. Sorry, it's hard to pronounce. And apraglutide is designed to support gut mucosal healing. So it could complement ruxolitinib's immune modulating effect. And so the early data they showed at the annual meeting, they seem to be very promising, especially for patients who are not responding very well to steroids, so who are steroid refractory. And I think there it's very important to have other treatment options, and to see something going on. But yeah, besides also belumosudil is coming to the market in Europe. I think in Michelle, you already can use it. Yeah. But for the European centers, it's quite nice to have this treatment available during this year. Sometimes I don't know when they will launch it, but I think this will also be very good opportunity to offer more options to our patients, because besides that, it's only offered in studies, and then you need to be part of the study. Yeah.
And it brings a lot of hope for patients, I think, doesn't it? That to know that there are, you know, potentially there's investment in new drugs, and that these are eventually hopefully becoming available for people. But of course, you know, at the moment where we're at, there isn't one single drug that is the kind of magic golden ticket. It's you know, we're back at looking at how we use these drugs in combination with other agents to be able to optimize the benefit that they can offer. Yeah, I think that you know, I think when we were working within the kind of COVID, and I just want to go back to the U paper that you mentioned earlier, that we were able to see different things being able to be utilized, different agents being utilized, because we were less keen to bring patients to the hospital for treatments like ECP, for instance. For a short while, it was more difficult to deliver that. And I just wondered, because I noticed in that paper that the data was collected between May and maybe October, I think, of 2020. Do you think that maybe influenced at all the data that was collected and the patient perspective of their graft-versus-host disease?
Yeah, that's actually a good question. Because we also started our study or our data collection just with the beginning of the pandemic. And it definitely influenced our data, because the symptoms were a bit different, I would say, than before and afterwards. They were more like, how do you say, respiratory symptoms. They are related symptoms. They had more cough or more influenza-related or COVID-related symptoms, but also anxiety might be different because, as you mentioned, many patients were very cautious. They didn't want to come to the hospitals and they stayed longer at home. And we also saw that in some cases, the GvHD was quite advanced before they came to us. And so the treatment was delayed actually. And this is really concerning because we know that every GvHD worsening should be addressed very fast, because if it's going to the severe pace, it's hard to get it back to a mild form or to even treat it appropriate. So I think, yes, this might be, of course,
There are, I think a lot of papers that were produced during or utilized data from the early, taken from patients using PROS during the early part of the pandemic. I think we have to kind of think about that and the influence of those times on the way people felt about their health and the way they might have reported conditions either to their clinicians or in a survey. Those things potentially would also be a little bit different. I think it's great that there is, there's lots of organizations trying to do more to highlight the issues around graft versus host disease. And, there's now a no GvHD portal that can be utilized by health professionals and also patients. There are loads of examples of patient stories on there. So for health professionals who are interested in understanding more about the patient perspective and the patient experience of graft versus host disease, there are some very useful resources there. In fact, no GvHD had a stand at the annual meeting, and the word is getting out there about the work that this group are doing. There's also an annual graft versus host disease day. I think it happens in February, and so it's unfortunate that we weren't able to use the podcast to be able to promote that a little bit this year, but that will come around, and there are lots of other widely available GvHD related resources. Lynn, is there anything that you use in your practice that and Hilda, anything you use in your practice to help support GvHD education, either for patients or health professionals?
For Germany, it's actually quite hard to find a good platform. The one you mentioned, No GvHD, I talked to them during the annual meeting and they promised to translate it in different languages. So I'm really looking forward to that, because there's not much for Germany or for German-speaking countries so far. So, and I think this would be very helpful to have more educational materials for nurses, but also for patients. You can give them along and to support them better in understanding about their disease and their symptom monitoring and how to react properly, and all these things we already discussed. But Hilda, maybe you have the magic tip.
No, totally agree with you, Lynn. Unfortunately, as far as I'm aware of, we don't have those information things in the Netherlands as well. But it would be very good, because it's really important to support more these patient categories and to relieve the symptom burden for these patients, also by giving them those information, of course. That's definitely sure. Probably as a last question to come to this podcast to an end, it's Lynn, do you have a case example in your mind from a patient, or probably do you remember a very insightful experience from a patient which you want to share with the listeners as an important lesson?
Maybe. So are you referring to gut GvHD or GvHD in general? Because I have many patients with GvHD in general, but especially gut GvHD is mostly very impressive, because it's so affecting their mortality. And I think they also aware of it, that it's really it can be life-threatening, and also the nurses. And I found it always very impressive if patients fight through these phases. And I presented one case example at the annual meeting, and still he is the one I'm mostly impressed by, because he had 4 episodes of really severe gut GvHD, and he always managed to go through these really challenging phases. And at the end, we had to take out a part of his gut, because it was very focused on this part, the GvHD, and when we took it out, we could solve it, and then he was symptom free afterwards. But still, this is also has an impact on the patient's life afterwards. But still, he is really in a positive person, and takes it quite good. So I hope that I always try to connect him with other patients experiencing the same trajectories, because I feel like he could give them some hope that there's still light at the end of the tunnel. Yeah.
Yeah, that's really important. And you always will remember those experiences of those patients. I always also remember such a kind of patient so long with us on the ward. And he said also that it really would support him if we helped him to set daily goals, and not only daily goals, but also weekly goals. And I think that really, as you said, supports their hope to get through this period, and to hope for a cure, probably. Do you also have such an experience from your experience, Michelle?
I mean, I've had many patient cases. I think probably we're out of time to be able to discuss too many more. But I think that the examples that you used were excellent. So it's time to bring this episode of the podcast to an end. I want to say a huge thank you to Lynn for joining us, and thank you, Hilda, for co-hosting. I think we heard a lot about gut graft-versus-host disease, but then it also feels like we really just scratched the surface, and there's so much more that we could talk about on this particular topic, looking at GI GvHD, but also, of course, graft-versus-host disease more generally. Of course, some of the things that we discussed today, we will be able to bring into other podcasts on graft-versus-host disease. We talked about some of the resources that people can access, so please do visit the EBMT website to pick up those links. I want to say thank you to the background team for their support with the podcast, and look out for the publication date of the next episodes, and thank you for listening. Thank you.
We are very interested to hear your thoughts on the topic we covered in this pod. What would you add from your experience? It would be great to hear from you either via email or on the EBMT website. Title your comment Blood Matters, or you can leave a comment on YouTube or Spotify. Don't forget to have a look at the resources mentioned in this episode. And thanks again for joining. Until next time.